Distinguished colleagues, I have no financial disclosure in this presentation, so you have seen that all our speakers have this slide as a must. And before speaking about the prospects of the medical and laser-based treatments, I cannot avoid all the main retrospective steps of the history made here. It's interesting that the story of the local treatment is already 150 years old, and the first drug which was used in glaucoma treatment had a very unpleasant name, some particular Pacific beans, and it was alkaloid, it was meiotic, that was actually released when Andrew Weber just offered his surgical reductomy. And actually it was a great help. In fact, it was sort of a preparation to the surgery because in the narrow pupil it was easier to make this manipulation. And only several years later, when pilocarpine was already discovered, they found out that meiotics itself can reduce IOP and even to resolve the attack. Then the era of adrenergic drugs came, and epinephrine was dominating for a long time in combination with pilocarpine. Probably you recollect that for many years there was adrenopilocarpine available, and current alpha adrenergic drugs like brimonidine came much later. This is already by the end of the previous century. The very important discovery was made in 1950 by Professor Baker when they found when diacarb can reduce intraocular pressure. But then it took 20 more years when Marine finally managed to synthesize that molecule that reduced intraocular pressure when dropping in. But the golden era of the topical treatment of glaucoma started from beta blockers. First not selective, later on selective like betaxolol. And these works of the beginning of 1980s by Zimmerman Kaufman, in fact, appear to be very symbolic in this turn when the next revolution happened, so when prostaglandin analogs came to stage, when they simply studied pro-inflammatory agents and suddenly accidentally found out they can reduce of IOP, and this is Adler's discovery of 1935, but only 50 years later, Hungarian chemist Laszlo Bito synthesized latanoprost molecule, and later studies with Carl Kambras in Columbian University. So this is a huge series of clinical trials when they managed to show that latanoprost very effectively reduced IOP in a single application, and this is a long-standing effect. Everything I showed before is shown in this scheme by Professor Travesso, published in 2005. So in between the centuries, we have a big spectrum of drugs to reduce IOP. But still, there was a big open question, what else can be offered for glaucoma treatment, neuroprotection, improvement of the ocular hemodynamics? And now, in fact, we are in the new pre-era in glaucoma treatment, and I will speak about later on. What drugs can affect those that we use in our practice? If we take meiotics, and we talk a lot about that today, that definitely sclera and sclera trabecula is improved. These are the only drugs that improve anterior outflow pathway, those who reduce IOP, influencing alpha and beta receptors, and there are many of them there, especially in the vessels. That's why we have so many AEs that, again, now very clear in the beta blockers and alpha adrenergic drugs administration. That's why the discovery of prostaglandin analogs that are improving posterior outflow options was quite a breakthrough. And for many years, these drugs took the niche of the first-line treatment, the starting treatment in the treatment of this disease. Well, first latanoprost, later on travoprost, tafloprost, Riscula has not been used in our country yet, but not surprisingly, 1 drop a day, and you reduce IOP by 30%. Moreover, now in our portfolio, we have lots of generics of latanoprost. I even didn't try to count them here, because as far as I know, even in Italy, just in Italy, we have more than 86 latanoprost generics, and all that makes it possible to treat glaucoma quite effectively, and our speakers were mentioning that today. Just 20 years later, the clinical trial was made, which is UK GTS, that showed that latanoprost not simply reduced IOP, but also improved the visual function, stabilizes, protects the patients from progression. And this study, which has already been mentioned several times today, is a very important, revolutionary, not because this is multi-center placebo-controlled trial, but look, 11 perimeters for 2 years. So that's exactly the key to success that opens the opportunity to study neuroprotective effects in the future. And this is exactly what Professor Martin was speaking about today, because very easily you can catch glaucoma progression, and this is exactly what was done here. And also 1 year later, they managed to prove that latanoprost reduces glaucoma progression versus placebo group, the group where no drugs were administered. And then by year 2, the significance was just increasing. Today, it seems to us we know everything about PA, prostaglandin analogs. We know their adverse events, growing lash, darkening lids, whatever. These are all pro-inflammatory properties of prostaglandin analogs. No, not surprisingly. That's why there is frequent discussion to stop or to administer because of surgery, cataractal surgery, specifically phaco. Recently, we made this study pretty fast using new technologies, which is OCT angio. We had 3 groups. In the first group, tafloprost. This is newly onset glaucoma. The second one, it was combination tafloprost plus timolol. And the third group got no treatment. And within 1 week, we followed these patients, hoping that with dramatic reduction of intraocular pressure, the circulation in the optic nerve would be increased, and we got totally opposite result. What we got is a dramatic reduction of circulation in the optic nerve skirt in head in patients who got treatment. Also with the treatment, there was thickening of paraphobia areas in the macula, paraphobia, and this is internal layer of the retina, which was not seen in the control group. Of course, this is not enough to make any massive conclusions, but we analyzed some literature data and we found one article on that. Yes, with prostaglandin analogs, they observe thickening, central macular thickening. This is 1 year follow-up data, and it reflects pro-inflammatory properties of these drugs. And although we did not speak about the clinically significant ocular edema, but in fact we saw that, and I'm sure it causes us to be more precise, more selective in the patient selection, where we demonstrate this, where we use this treatment due to the cataract surgery. Speaking about anterior segment, we remember very well that these drugs cannot be administered if there is some predisposition to herpetic keratitis, and this is one more important problem that they try to overcome when they administer local hypotensives delivery route into the eye. So how to avoid adverse events and other problems associated to the drug treatment of glaucoma. For example, Allergan company offered to deliver bimatoprost, the drug which causes pretty severe hyperemia and inflammation, as an implant into the anterior chamber, anterior segments. So these implants, they could be ongoing for 1 year in the eye, slowly releasing the drug and providing normal level of ophthalmic tonus. But they showed also that 3 times rarer, these drugs can lead to the local adverse events. Is that important? Definitely, definitely. As you probably understand, this is an invasive procedure if implant is introduced in the anterior chamber. That's why the company made step forward. And what they did is ring with the matoprost. It puts into conjunctiva, being there for 6 months, also releasing the drug, which is reducing intraocular pressure. So they tested the treatment for 300 patients, and 85% of patients were showing that this is more convenient versus putting in drops. So here are interesting, very interesting delivery routes. Next option, implantation of the drug is a particular under conjunctiva implantation, also microsurgery, but the effect up to 1 year, you can keep effectively hypotensive effect. So if you do it as under conjunctiva injection, so this is short effect for 3 to 4 months, but also this effect is very known. But the most popular way, which is coming through the phase 3 of clinical trials, these are occluders. like it was done in the dry eye syndrome. So occluders are introduced into the tear-releasing glands, so they slowly reduce the pressure, and for all prostaglandin analogs, such occluders have been passed through the clinical trials. What is very important in the glaucoma treatment is the introduction of the fixed dose combinations. This is very convenient and effectively reducing the pressure. But look, Temodol here with all its adverse events. That's why fixed combination, which is Timolol free, which is without beta blocker, is very attractive option. And in this context, I cannot help reminding brimonidine with brinzolamide combination, which is actively used globally. And we do hope that very soon it will be available also in Russia. It contains carboanhydrate inhibitor, which is brinzolamide. Well, I have to say that this group of drugs not simply improve the ocular circulation, but also provide some additional effects, which was multiply shown in our trials, which is very high antioxidant effect of carboanhydrate inhibitors, including brinzolamide. But the very important player here is brimonidine. Brimonidine is a drug which, in fact, the only currently drug with evidently based, both experimentally and clinically, direct neuroprotective effect. We always speak about this study, normal pressure glaucoma. This is multi-center American study where they show that with brimonidine, the disease is progression rate is 3 times lower versus timolol. By the way, well, we are using it very actively, Lixvan, Pifogan, but very recently it has been proved that this drug can provide positive influence to the hemodynamics, retinal vascular autoregulation, not by short-term IOP reduction, but influencing NO synthase. And this is very fresh clinical trial from 2017. It appeared to be when they compared brinzolamide brimonidine, which is fixed combination, versus timolol, they found out that at nighttime, timolol does not reduce IOP, and you know that, but the fixed combination does it. But what is worse here, timolol reduces perfusion pressure, PP, due to the specificity of its circulatory effect. So we can expect it also in the fixed combination containing timolol, whereas the fixed combination brinzolamide with brimonidine does not have this negative effect of the perfusion pressure. This is important because a classical phrase of Professor Rich, he couldn't say that glaucoma is nocturnal disease, especially normotension glaucoma, and reduction perfusion at night time. That's a catastrophe for the patient. So let's come to the new perspective. So if we used to influence just the scleral compartment and alpha and beta receptors in the eye, now all the attention is focused on the trabecular mesh. And this is what exactly Professor Burgoyne was speaking about, trabecular, and not specifically trabecular. For the last 20 years, they're studying so-called juxtacanalicular part of the drainage area, where there is a maximal obstacle to the outflow, resistance to the outflow. So it appears to be that there are two very important things that were discovered very recently. The first one is trabecular has contractility activities due to the actin protein. So it can shrink, regulating the outflow no matter what ciliary muscle of the is doing. So such cross-linked actin network is very actively discussed, because when it happens, it's like sticking of this actin when the trabecula loses its contractility, and finally outflow is dropped down. And the second thing, which you probably saw, that all the speakers were using that extracellular matrix all the time. So ECM. So in any form of glaucoma is accumulated in the juxtacanalicular parts, and it is ECM is the obstacle of the outflow and the reason of IOP high rise. So all new is well forgotten old. You remember 20 years ago, we spoke a lot about NO in the glaucoma pathogenesis. Even Professor Joseph Flammer wrote the monography about that, where he said that NO production reduction leads to the reduction of the outflow. And probably we were the first in the world who measured the NO level. In fact, its metabolites in the aqueous outflow, and we showed that the NO production is 10 times lower in the advanced stages of glaucoma versus initial stages. So this is the data of 2001 in ophthalmology newsletters. And then our colleagues, pathophysiologists, asked us why. Why is that so? Why don't you use NO? NO for providing effective outflow for glaucoma treatment, but it took 20 years in order to synthesize the molecule which can regulate this outflow, and it was also merged with latanoprost, where NO is released after the instillation. So that's a wonderful combination with Zoltan, which is nitric oxide donating prostaglandin F2 alpha analog. So I cannot show you the video, but you can appreciate here. So this is overscleral and posterior effect as well due to latanoprost. The next group, which is also very perspective, which is mentioned by Professor Bercoin, the inhibitors of Rho Kinases. I would like to explain once again what is that. Rho Kinases are specific enzymes that are doing many bad things in the anterior segment. So these are the drugs, these are substances that increase the adhesion, which is sticking tissues in between and narrowing Schlemm channel, and increase the rigidity, the stiffness of the endothelium, and increase the deposition in the cellular matrix in the juxtacondylar zone, which leads to the increase of IOP. That's why the drugs that inhibit Rho kinase activities could be very effective towards IOP reduction, and exactly that was shown in the experiments in the bovine eyes, in the monkeys. And dear colleagues, what we are talking about today when we discuss the outflow, aqueous outflow, now we have new definition, which is effective filtering area, EFA, which is exactly in the juxtacondylar part. And with Rho kinases installation, we can increase the aqueous compartment in the juxtacondylar compartment, which means there is effective outflow. Additional and very important properties of Rho kinase is shown here. First of all, increase the circulation for the optic nerve head, increase survival of glial cells in ischemia and reperfusion, what is very important in surgery, reduction of scarring of the outflow pathway because this adhesion is removed. And again, very successfully, Rho kinases inhibitors were merged with one more new molecule, which reduces the production of the intraocular fluid. But this is not via alpha-beta factors receptor. This is norepinephrine transporter, NET, when two such molecules are merged in one drug. So we have double effect. First of all, increasing of the anterior outflow mechanism and reduction of the intraocular fluid production. Then one more step forward, and they added to this combination very famous latanoprost molecules, and finally rocklatan came to stage, which has triple effect. And then I emphasize that first of all, this is anterior segment outflow and posterior overscleral, and the fluid production rate reduction, and it was tested for 500 patients, and there is 1/3 drop down of IOP. But unfortunately, here there is some AE, which is hyperemia, which could be overcome by new delivery routes. So colleagues, very soon we are expecting totally new drugs that will come on stage for the glaucoma treatment, which is Visulta, Ropreza, and Rocklatan. And I'm sure now you can recollect what all this means, and in any way you understand what could be the modes of action. One more molecule, which is not so close to the coming to stage. It's one more group of drugs, matrix metalloproteinases, which is MMPs, and particular enzymes that can split extracellular matrix, and these are MMPs, matrix metalloproteinases. In fact, the release of these enzymes is increased when there is excitation of adenosine receptors in the eye. There are many of them, they're everywhere in the anterior segment, and stimulating them, we can observe particular enzymes, MMPs, that can split extracellular matrix inside the juxtacondylar layer. But adding to that, there is improvement of ganglion cell survival, with glucan-med calcium cascade. There is increased circulation in the optic nerve disc. And please appreciate how these neuroprotective properties of this group were already studied. If we think about the using of this substance in the treatment of the neurodegenerative diseases such as Alzheimer. You can appreciate that this is complex effect that could be observed when such drugs would be available for glaucoma treatment. I believe there would be no need in surgery in many cases. I believe so, if there would be such complete effect. And what is very far from clinical trials are MMPs per se, and also no growth factor, NGF. This is exactly what we discussed with Keaton Martin, which is very perspective. I believe the drug which reduce IOP at all, but stealing the eye, and this is phase 2 clinical trials, you can improve the survival of ganglions, which is important. Coming to laser treatments, I would like to say that again, retrospectively, the story of laser treatment is much younger versus conservative treatment, but still, in the beginning of the 20th century, the first laser iridectomy was performed, and only 30 years later, it has been implemented actively into the clinical practice due to the Abraham lens and due to the implementation of by Frank Hauser, YAC laser. But by the way, very many of our Russian studies introduced their contribution, Dr. Krasnov, for example, and I believe the true era of laser glaucoma treatment started in 1979 with urban laser trabeculoplasty, which was offered by Weiss and Witter. And the next breakthrough, this is 1995, Mark Latina introduced selective SLT approach. So as soon as trabeculoplasty came on stage, so multi-center studies were immediately initiated. It was shown if you start glaucoma treatment from trabeculoplasty, then later on the IOP would be in a lower range, so you require fewer drops to keep the normal range. Now we can say there is particular renaissance of that story. So the question is whether SLT can be the first line treatment in glaucoma treatment. Yes, very disputable. Quite recently, there was a very big review on that, of all the articles where they compared SLT versus first-line treatment, mainly latanoprost, as a first line of glaucoma treatment. It has shown that hypertensive effect, both SLT and these drugs, is the same. Now ask the patient what he or she likes more, probably perform laser, which is totally pain-free and very easy to perform and without any drops. But that's the problem. First of all, it was shown that fluctuation of IOP is still available, and these excursions are more pronounced after SLT versus latanoprost. Then why still yet SLT is not in the standard as a first-line treatment? Not only because many patients have ophthalmic hypertension, which can be overcome successfully. I mean, reactive hypertension. The first hour is post-op, but the fact that patients later on do not return and they believe they are cured, that's a serious challenge. The patients have to be explained that the procedure is playing not longer than 18 months, and then you have to repeat it and then follow that within this month and using drops. And again, 10 to 20% are non-responders, which are not responding to this treatment. It doesn't work here. But nevertheless, dear colleagues, I would like to emphasize that trabeculoplasty, specifically SLT, became the breakthrough in the glaucoma treatment and preservation of visual acuity for the hundreds and thousands of patients. Especially it is referred to the developing countries, the third world countries, and the confirmation of that is a very fresh publication in the American Journal of Ophthalmology. So Afro-Americans living in the Afro-Caribbean eyes, immediately with the glaucoma identification, they started SLT without any hypertensive treatment. And 1 year later, 78% of these patients reduced IOP by 20%, and this is important. It was normal range. In our country, we were the pioneers, and actually we were at the beginning of introducing SLT in the clinical practice. Our first publication was done in 2004, and now having long-standing results to follow up. Probably this is the biggest database, and we don't see anything similar with such long-standing observations. We compared SLT efficacy in different forms of glaucoma. Of course, we start treating patients earlier. And this is pretty high. This is Kaplan-Meier curve, or the efficacy of the hypertensive effect during these years is pretty high, both for POAG and in the PXFG, and what is very important, in the PICG. So very important issue, first iridotomy, then SLT when the angle is open, and believe me, it works very effectively. According to our data, in the long-standing periods, the better results were seen in this category of patients, and we did not find any publication in the literature about such long-standing follow-up with the patients of this group. And this is one Singapore study, multi-center study, but their follow-up period was just 1 year. We have more than 6 years. But the procedure doesn't work in the pigment glaucoma. So new methods are offered now, laser methods, in order to have milder influence to trabecule. And I had a question here, and my colleagues asking what is better, SLT or MLT? And there were some clinical trials that show the absence of statistically significant difference between the hypotensive effect of these procedures. Just like the pattern SLT, PSLT, when the impulse comes with particular patterns simultaneously, 56 points. So yes, very convenient for the patient, and that's the end of the limit. Advantages of this procedure. So Swiss ophthalmologists, they compared one eye, it was pattern SLT, the other eye was classical SLT, and in a long-standing period, there was no difference in the hypotensive effect. Sometimes they offer even SLT without gonioscopy, and this is very fresh data. Just from Limbus, you put the application with the same indexes, and the authors are saying that 1 year later, no, 6 months later, the effect is the same, speaking about transscleral selective laser trabeculoplasty with and without gonioscopy lens, but still 1 year later, the classical SLT gives better efficacy, 33 versus 20. So we should not repeat, because the surgeon should see the field where he or she works. Pigmentations, yes, these are very important. Synechias, everything should be taken into consideration. Now, cyclodestructive procedures, very well known for more than 50 years already. And always, when we're speaking about cyclodestruction, first of all, we mean refractory glaucoma, very advanced stages in blind eyes. Why? The effect is unpredictable. And we don't know what could be the complications. It's very difficult to influence them, so sometimes it can be phthisis of the ball. But still, the works were done, and currently, together with the classical diode cyclocoagulation, when they use classical G-probe zones to effectively reduce pressure via coagulation of the ciliary body. But there is another type of probe, which is called micropulse transscleral cyclophotocoagulation. This is MP3 probe. Can you start the video, please? Can you start the video, please? You cannot. So here at the bottom, there is a video, because in fact, the study was made, the pre-made study, APE study in Massachusetts University, and they showed that when there is a laser effect towards ciliary body, so no coagulation and ciliary muscles. Could you start the video, please? The arrow in the bottom of the slide. Yes, here. So with that, there is a shrinkage of the ciliary muscle. It's either prolongs and then shrinks, and this is how we can tension of the trabecula is improved. So that means anterior outflow is increased, and that's exactly the mechanism of how it works. By the way, histologically in the specimen, it was shown that no coagulation happens here on the right. There is coagulation, and on the left there is no coagulation. The procedure is very simple for the patient. So it performed with a local anesthesia. So the probe is not moved from the eye. So this is continuous effect. Well, actually several seconds. It's ongoing. And this is very important, that there are already clinical trials, and Singapore study specifically showed that the IOP is 30% reduced, and it's a sustainable effect for 18 months follow-up, and the need of drops also 3 times reduced. If even initial IOP is not very high, so still this hypotensive effect is very effective. Again, minus 30% of IOP. So I believe this is very perspective direction in the glaucoma treatment. And last but not least, which is truly cyclodestructive procedure, which is very popular abroad, high-intensive ultrasonic circular cyclocoagulation. So this is very complicated name, but in fact, this is ultrasound effect. What does it mean, ultrasound, that is influencing the tissues? So in fact, it's increased temperature by 90 degrees in the tissues, and this is tissue vaporization. and there's a huge risk of complications, and actually it stopped. When 50 years ago Coleman made this study for the first time, actually it stopped further development. Now it's used in oncology for the destruction of tumors, but even now, only nowadays, when we have the option to control this effect, there is a particular renaissance of this high-intensity focused ultrasound circular cyclocoagulation. So it's simply on the eye, fixed with vacuum, and the doctor is doing nothing, he's simply pressing the pedal. And here inside in the probe, there are 6 piezoceramic transducers, and ultrasound goes through consecutively in the different sectors of the eye, and there is a heating, and doctor can observe it because there is a panel with infrared mapping, and you see how the temperature is increasing. With that, both lens and the cornea are protected, no side effects, and this is extremely important. Although it was reported that sclera is thinning and there are particular cavities in which could be considered as a positive effect of this procedure. And unfortunately, not so many clinical trials were made, and maybe Stefano will add on later on, because I know that in Italy, in different centers, some studies were carried out for this machine. At least multi-center clinical trial was published by the French group in Ophthalmologica. They showed that the effect was reached in 63% of patients. But again, it was IOP reduction by 30% from baseline. But what's very important, they're saying that procedure is so safe that it can be easily recommended to patients with ophthalmic hypertension and initial glaucoma, OTH and initial glaucoma. Can you imagine how cyclodestructive understanding was changed? So wrapping up, dear colleagues, today we are waiting for the new era of the conservative treatment, local treatment of glaucoma, when it could be focused on the improvement of the anterior outflow, and the drugs and options will have very important properties, neuroprotection and improvement of the ocular circulation. The delivery routes are changed, and the most important I would to emphasize, it will let us to overcome the problem of patients' compliance to treatments. So there is no need to forget to have drops in the eyes. And last but not least, laser will become milder and more effective with fewer AEs, which improve anterior segment outflow, and laser cyclodestructive interventions would be milder and better prognostic. Thank you very much for your attention.